Cephalosporins. Considered safe during pregnancy, with most studies showing no fetal harm. This article reviews the safety of different types of cephalosporins, including the FDA and TGA classifications, and their common uses during pregnancy. All classified cephalosporins to 4 groups based on the FDA and TGA categories. The groups are arranged from the safest to the least safe during pregnancy according to FDA and TGA categories. Here is the arrangement of cephalosporins according to safety, starting with the safest based on FDA and TGA categories. 1. FDA category, B. TGA category, A. Include, first generation, cephalexin, cephradine, cephalothin. 2. FDA category, B. TGA category, B1. Include, first generation, cephadroxil, cefazolin, second generation, cefaclor, cefoxitin, cefurazime, cefamandole, cefatadine, third generation, cefixime, cefataxime, ceftazidime, ceftriaxone, cefoperazone, cefpodoxime, cefdinir, fourth generation, cefapime. 3. Less safe FDA, not assigned, TGA category, B2. Include, third generation, cefadizime, fourth generation, cefpurome. 4. Use only if essential, limited data or animal toxicity. Include, third generation with beta-lactamase inhibitor, ceftazidime with avibactam, ceftolizane with tazobactam, fifth generation, ceftaroline fosamil, ceftobiprole. Now, let's talk in details. 1. FDA category, B. TGA category, A. First generation, cephalexin, Ceparex 1 gram, Keflex 1 gram. Compatible with pregnancy. First-line oral therapy for uncomplicated UTIs, cystitis, asymptomatic bacteriuria. Not recommended for pyelonephritis as monotherapy. Requires initial IV ceftriaxone or cefapime ACOG. Cephradine. Velicef 1 gram. Cephradine 1 gram vial. Used for mild to moderate bacterial infections, UTIs, respiratory, skin infections when susceptible organisms are suspected. Newer cephalosporins cephalexin or cefazolin are often preferred due to more robust clinical data, better availability, and familiarity in guidelines. Cephalothin. Less commonly used today, often recommended for infections like UTIs or when penicillin alternatives are needed. Cephalothin is safe in pregnancy but not a first-line agent due to declining use, replaced by newer cephalosporins. Limited contemporary data compared to alternatives like cefazolin or cephalexin. 2. FDA category, BTGA category, B1. First generation, cefadroxil, Doracef 1 gram, Curasafe 1 gram. Compatible. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Uses. Alternative for UTIs, similar to cephalexin but less frequently used. Limited direct guideline support. Use based on institutional protocols, CDC, ACOG. Cefazolin. Zino 1 gram vial. Surgical prophylaxis for cesarean delivery, ACOG. Intrapartum GBS prophylaxis in penicillin-allergic patients without anaphylaxis, ACOG. Emphasize avoidance in severe penicillin allergies, IgE-mediated reactions, due to shared beta-lactam structure. Second generation, cefaclor. Compatible with pregnancy. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Respiratory ear infections, limited use in pregnancy. No specific pregnancy guidelines, use cautiously. Cefoxitin. Primafoxin 1 gram vial plus Fox 1 gram vial, Mafoxin 500 mg tablet. Compatible with pregnancy. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Pelvic, abdominal infections, chorioamnionitis, postpartum endometritis, ACOG. Cefurazime. Compatible with pregnancy. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Uses. Respiratory, skin infections, pneumonia, cellulitis, RCOG. Sepsis regimens combined with metronidazole for polymicrobial coverage. Avoid in severe penicillin allergies, no longer first line for sepsis in updated protocols. Cefamandole. Cefamandole is not a first-line choice in pregnancy due to potential bleeding risks. NMTT side chain. Inhibit vitamin K metabolism, increasing the risk of bleeding. Limited contemporary safety data. Availability of safer alternatives, cefazolin or cefuroxime. Cefatidine. Alternative to cefoxitin but longer half-life for intra-abdominal pelvic infections. Cefatidine is not recommended as a first-line agent in pregnancy due to bleeding risks from its NMTT side chain. Lack of robust safety data compared to other cephalosporins. Safer alternatives, cefazolin for prophylaxis, cefoxitin, ceftriaxone for infections. Third generation, cefixime, Suprax 200 or 400 mg. Tablet, compatible with pregnancy. The limited human pregnancy data don't suggest embryo-fetal risk. Oral alternative for gonorrhea only if ceftriaxone unavailable, CDC STI Guidelines, 2021. Not recommended as monotherapy due to resistance concerns. Cefotaxime, Cefatax, Foxum, Zorin, Sporin and Ramatax 1 gram vial. Compatible with pregnancy. There is limited human pregnancy data with cefotaxime. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Meningitis or sepsis requiring broad-spectrum coverage, RCOG. Ceftazidime, Fortum, Cefzim and Kefidime vial. Compatible with pregnancy. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Pseudomonas aeruginosa infections, hospital-acquired pneumonia, sepsis. Limited pregnancy-specific data, used based on microbiological need. Ceftriaxone, Sfax1 and Zoraxin 1 gram vial. Compatible. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Note: manufacturer advises use only if the benefit outweighs the risk. Limited data available but not known to be harmful in animal studies. Specialist sources indicate suitability for use in pregnancy. First line for gonorrhea, 500 mg IM plus azithromycin 2 grams oral, CDC STI Guidelines, 2021. Severe pyelonephritis, sepsis, IV therapy, ACOG. Its use in late pregnancy is approached with caution due to the potential risks to the neonate. Cefoperazone, Cefazone, Sfobit and Cefron 1 gram. Indications: serious infections requiring broad gram-negative, anaerobic coverage, intra-abdominal, pelvic infections. Cefoperazone is not recommended for routine use in pregnancy due to bleeding risks associated with its NMTT side chain. It should be reserved for life-threatening infections resistant to safer alternatives. If used, limit duration of therapy. Monitor coagulation parameters. Supplement vitamin K. Cefpodoxime. Cefpodoxime is safe for use in pregnancy but is not a first-line agent due to limited pregnancy-specific data compared to older cephalosporins. Availability of alternatives with more robust safety profiles like cephalexin. Cefdinir. Cefadierode 300 mg and Maxdinir 300 mg tablets. Cefdinir is not a first-line agent but may be used for infections requiring oral third-generation coverage, resistant UTIs, sinusitis, mild to moderate respiratory, skin infections. Fourth generation, Cefepime, Cefpium, Maxipime and Vanzapro 1 gram vial. Compatible with pregnancy. Manufacturer advises caution, no data. Available but not known to be harmful in animal studies. No reports describing the use of cefepime in human pregnancy have been located. Nosocomial infections, e.g., multidrug-resistant pneumonia, sepsis. Reserved for cases with resistance to first-line agents, extended-spectrum beta-lactamases producing organisms E. coli, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter spp. No specific pregnancy guidelines, reserved for severe cases. 3. FDA, not assigned, TGA category, B2. Third-generation cephalosporins. Cephadizame. Used for severe infections requiring broad gram-negative coverage, e.g., resistant Pseudomonas enterobacteriaceae. Cephadizame is not recommended for use in pregnancy due to bleeding risks from its NMTT side chain, lack of human safety data compared to other cephalosporins, availability of safer, equally effective alternatives. Fourth-generation cephalosporins. Cefpirome. Used for severe infections requiring broad gram-negative and gram-positive coverage, like Pseudomonas aeruginosa, Enterobacter, methicillin-susceptible Staphylococcus aureus. Cefpirome is not a first-line agent in pregnancy due to limited human safety data compared to older cephalosporins. Reserved for multi-drug-resistant infections. 4. Use only if essential, limited data or animal toxicity. Third generation with beta-lactamase inhibitor. Ceftazidime with avibactam. Zavicefta. Manufacturer advises avoid unless potential benefit outweighs risk. Toxicity in animal studies. Compatible. No detectable teratogenic risk with cephalosporin antibiotics was found in a large 2001 study. Ceftolizane with tazobactam. Zerbaxa. Manufacturer advises to use only if potential benefit outweighs risk. Toxicity in animal studies with tazobactam. Resistant Pseudomonas or ESBL infections like complicated UTIs, intra-abdominal infections. Strictly for life-threatening infections with confirmed resistance. Fifth generation. Ceftazidime furosemide. Zinforovial. MRSA infections like skin, soft tissue, pneumonia. Manufacturer advises avoid unless essential. Limited information. Animal studies do not indicate toxicity. Minimal pregnancy safety data. Use only if no alternatives. IDSA MRSA guidelines. Ceftobiprole. Life-threatening infections with suspected confirmed MRSA or multidrug-resistant gram-negative pathogens. Ceftobiprole is not recommended for routine use in pregnancy due to limited human safety data compared to older antibiotics. Reserved for resistant infections. Manufacturer advises avoid unless essential. No information available. Conclusion. According to 2001 Zeisel study, first per second generation cephalosporins showed no teratogenic risk. Newer generations 3rd, 4th, 5th were not studied but are considered safe by guidelines. While cephalosporins are pregnancy safe, their use requires 1. Avoid NMTT-containing agents like cefatidine, cefoperazone, cefamandole in late pregnancy due to bleeding risk. Carry risks of hypoprothrombinемia and bleeding due to vitamin K depletion. Disulfiram-like reactions. Avoid alcohol during, after treatment. So avoid NMTT-containing agents in late pregnancy, 3rd trimester due to neonatal bleeding risks. But if prolonged therapy is unavoidable, monitor PT/INR if used for greater than 3 to 5 days. Supplement vitamin K 10 mg per week orally if prolonged therapy is unavoidable. 2. Allergies and cross-reactivity. Avoid cephalosporins with shared R group side chains like cefazolin and cephalexin in severe penicillin anaphylaxis. Penicillin allergy. Cross-reactivity risk is 1–2% for first-gen cephalosporins like cephalexin and less than 1% for later generations. 3. All cephalosporins, especially broad-spectrum agents, increase the risk of antibiotic-associated diarrhea and C. difficile colitis. So, use the shortest effective duration to minimize disruption of maternal gut flora.